So one day, a guy with bad gas goes in to see his doctor. He says, "Doc, you gotta help me. I can't stop farting. It's the weirdest thing. They don't smell and there's no sound, but they just won't stop. I farted 5 times while telling you this, and you see, you didn't even notice." The doctor then writes him a prescription and says, "Take this and come back in a week." A week later, the same guy goes back to the doctor and says, "Doc, these pills don't stop the farts. All they did was make them smell terrible. I can hardly stand it." The doctor replied, "Good. Now that your sinuses are cleared up, let's work on your hearing." Hi everybody, it's Dr. Ryan here with another hard-hitting algorithm in internal medicine. This is our 45th in the series, and our 5th in the discipline of endocrinology. We're going to be talking about hyperthyroidism. A big thank you to those of you who've been liking and sharing my videos and subscribing to my YouTube channel. And if you haven't done so, well, what are you waiting for? So today we're going to be touching on hyperthyroidism. Now, thyrotoxicosis is a clinical condition that results from thyroid hormone excess. Symptoms of thyrotoxicosis include heat intolerance, sweating, nervousness, irritability, anxiety, fatigue, poor concentration, palpitations, dyspnea, hyperdefecation, nausea, vomiting, menstrual irregularities, diplopia, and eye discomfort. Whew, that was a mouthful. Physical findings of thyrotoxicosis include weight loss, tremor of the extremities, hyperreflexia, tachycardia, systolic hypertension, tachypnea, goiter with or without bruit, abdominal tenderness, pelvic and shoulder muscle weakness, warm and moist skin, exophthalmos, eyelid retraction and lag, periorbital edema, and ophthalmoplegia. Now, younger patients with thyrotoxicosis are more likely to have hyperadrenergic manifestations, example, anxiety, restlessness, and tremor. Older patients tend to be less symptomatic but are more likely to develop cardiovascular complications like dysrhythmias. Now, thyroid storm describes a severe and life-threatening form of thyrotoxicosis with extreme signs and symptoms of hypermetabolism. When thyrotoxicosis is suspected clinically, it is confirmed with an elevated serum T4 level or free T4. Now, serum thyroid stimulating hormone or TSH level determines whether thyrotoxicosis is TSH independent or dependent, and that is the first point of departure on our flowchart. TSH independent thyrotoxicosis can be associated with increased or decreased radioactive iodine uptake. Increased radioactive iodine uptake can occur in a diffuse or focal pattern, which informs the differential diagnosis. Now, beta blockers can be used to ameliorate the hyperadrenergic manifestations of thyrotoxicosis, example, anxiety and tachycardia. Options for the long-term treatment of hyperthyroidism related to Graves' disease, toxic adenoma, and toxic multinodular goiter generally include antithyroid drugs, the likes of thienamides, radioactive iodine ablation, and or surgery. Choice of modality depends on the underlying cause, regional practice, patient-specific factors, and patient preference. Let's dig into this. So we said the first point of departure was TSH-dependent versus TSH-independent disease, right? TSH-independent versus TSH-dependent, right? So TSH-independent, here we're going to look at your radioactive iodine uptake scan. If there's increased uptake, look at the pattern. Is it diffuse or local? Diffuse or focal, rather. Right? So if it's diffuse, we speak to Graves' disease. And you know, the physical signs of Graves are very, very specific. It's pretubercular mixed edema with thyroidopathy, which is actually clubbing, and eye signs, ophthalmoplegia, lid retraction, lid lag, proptosis, and so forth, right? Then the other form of diffuse radioiodine uptake, which is TSH independent, is HCG induced, especially in the form of a hydatidiform mole or a molar pregnancy, right? If it's focal uptake, you're thinking more along the lines of, is this a toxic multinodular goiter? Is this a toxic thyroid adenoma? If you're looking at decreased uptake on the radioactive iodine uptake scan, you got to think about these 4 things, right? So exogenous thyroxine intake, thyroiditis, iodine exposure, or is it extraglandular in the way of, for instance, struma ovari? In TSH-dependent disease, here the TSH is high as well as the T3 and T4 is high. You're thinking a problem with the pituitary or the hypothalamus. It could be pituitary adenoma or impaired sensitivity to thyroid hormone. This is a nice illustration from George Muniz over at medcomment.com. Thank you, sir. Saying that Graves' disease is an autoimmune disorder that results in the overproduction of thyroid hormones and typically affects women 20 to 40 years of age. Okay, and just like how we see Gary Goiter here, and there's a lady at the graveyard. She's obviously so shocked by this hand that she sees coming out. So her eyes pop out. That speaks to exophthalmos. She gets diaphoresis, so she's sweaty. She gets a tremor. Loose stool, speaking to hyperdefecation. She gets tachycardia and arrhythmias. And remember, the Graves' disease is the most common cause of hyperthyroidism. So another handy mnemonic we can learn is Hashimoto's thyroiditis. This one taken from drkohari.com from a book called Medicine is Fun. All right, so each of these letters corresponds to a particular finding or feature. So H speaks to hypothyroidism features. A is autoimmune. As we know, Hashimoto's keeps company with the autoimmune polyendocrine syndromes. S speaks to synthroid treatment. H is Hertel changes histologically. I stands for initial hashitoxicosis. M is marginal zone NHL. G speaks to goiter. T is for antithyroid peroxidase and antithyroid antibodies, and O stands. It's a misnomer there. So O is actually lymphocytic infiltrate. Nice one. Here's an OSCE example. A 51-year-old woman presents with lower extremity swelling, pruritus, blurred vision, and swollen fingertips. Which of the following treatment is not used for this condition? So this obviously, as we know, the proptosis and the eye signs, together with the thyroidocropy, together with the pre-tibial myxedema, makes a diagnosis of Graves' disease. In Graves, the one thing you do not want to give the patient is thyroxine, because they're already in a hyperthyroid state. Adding thyroid hormone is not the best idea. All right, so as always, guys, I just want to encourage and motivate you this morning. Aristotle said, and I quote, that pleasure in the job puts perfection in the work. He also went on to say that the roots of education are bitter, but the fruit is sweet. Now, the Bible speaks about the concept of listening and doing, and this is outlined for us in the book of James, chapter 1, verses 19 to 27. I just want to read that for you this morning. It says, "My dear brothers, take note of this. Everyone should be quick to listen, slow to speak, and slow to become angry. For man's anger does not bring about the righteous life that God desires. Therefore, get rid of all moral filth and the evil that is so prevalent, and humbly accept the word planted in you, which can save you. Now, do not merely listen to the word and so deceive yourselves. Do what it says. Anyone who listens to the word but does not do what it says is like a man who looks at his face in a mirror and after looking at himself goes away and immediately forgets what he looks like. But the man who looks intently into the perfect law that gives freedom and continues to do this, not forgetting what he has heard but doing it, he will be blessed in what he does. If anyone considers himself religious and yet does not keep a tight rein on his tongue, he deceives himself and his religion is worthless." All right, so I pray that we will all be quick to listen, slow to speak, and slow to become angry. Have yourselves a wonderful day. I'll catch you tomorrow with another algorithm in internal medicine speaking to hypothyroidism. Take care. God bless.